Welcome to the Istanbul University Oncology Institute Seminars in Preventive Oncology. This is the 33rd seminar of the series. As you know, this series is also endorsed by the International Society of Pediatric Oncology. I'm Rejin Kebudi, a professor of pediatric hematology oncology in the Istanbul University Oncology Institute. Today, as always, we have a very distinguished guest, a very hot topic, Rhabdomyosarcoma, controversies in the management of rhabdomyosarcoma, and a very distinguished co-moderator. Before I introduce our guest speaker, I would like to introduce our distinguished co-moderator, Professor Bülent Zülfikar, who is also director of the Istanbul University and a professor of pediatric hematology oncology. Professor Bülent Zülfikar, thank you for co-moderating this session with us, and the floor is yours.
Good afternoon. Thank you very much, and good morning. So some part of the world. It's the international seminar of Istanbul University. Istanbul University, my department is Preventif Oncology in Istanbul University Oncology Institute. This is the 33 seminar. It's ongoing program. Thank you very much, Professor Kebudi, this very special organization. We know the childhood cancers, childhood chronic disease, and also some of the survivors after the cancer treatment. They have many difficult quality of life. The main problem is coming from the malignancy, but also we know the treatment has some disadvantage for the future. The best of the childhood cancer, the result of the best childhood cancer coming from the hematologic malignancy, but the brain tumors, bone tumors, and also soft tissue tumors are in the researcher working on for many years. One of the best researcher and best doctors in this field is our alumni in Istanbul Medical School, 1989. Yes, 1989. This Professor Fatih Okçu. I wanted to invite him for his very special, this Rhabdomyosarcoma seminar. Thank you very much coming to here. Thank you very much, Professor Kebudi. Thank you very much all the friends working on the pediatric hematology and oncology. Welcome.
Professor Bülent Zülfikar, thank you so much for the introduction. And now, before I would like to read the CV of Professor Fatih Okçu. We are very proud of him as a graduate of the Istanbul Medical Faculty. He was a graduate in 1989. After his graduation, he did his residency in the University of Texas in pediatrics and his pediatric hematology oncology fellowship in MD Anderson in Texas, Houston. And after that, since 2007, he has been in Baylor College of Medicine, Texas Children's Hospital, and he's a Prof professor and has also a Master of Public Health degree, in addition to his full professor in pediatric hematology and oncology. And he is in charge of the sarcoma and also neuro-oncology program in Texas Children's Hospital, Baylor College of Medicine. Professor Fatih Okçu, we are very proud to have you here, and we know you are one of the best in the field of sarcomas and rhabdomyosarcoma, and we are eager to listen to you on your lecture on controversies in the management of rhabdomyosarcoma, and I'm sure you will be telling about the controversies across the Atlantic in the two continents as well. Please, the floor is yours. You can share your slides now. And for the audience, we'll have the question and answers. You can write them in the chat. We will have question, answers, and comments at the end. Thank you so much.
Dr. Kebudi, this is the new platform of the international seminar, Istanbul University new platform. Thank you very much for our friends organizing this event for us.
Yes, this is a new platform especially for virtual education, and I hope this will be this is the first edition of the platform, and I hope it will be really beneficial for all the educations worldwide. Thank you so much.
Can you hear me and see my slides?
Yes, we can see you, and yeah, your slides also.
And it's in full screen, right?
Yes.
Okay, but thank you, Dr. Kebudi and Dr. Zülfikar for the wonderful introduction, and I'm very proud and honored to be here. And both Dr. Kebudi and Dr. Zülfikar are special people for me. They were either fellows or subspecialty fellows early on, or junior faculty when I was there, and they both taught me some things and during my medical school education. And Dr. Daoğlu also, thank you for the invitation and for this wonderful seminar series. And Dr. Daoğlu's parents were my teachers also during the medical school. So it's really wonderful to be here. What I want to do, before I do that, I'll just show you a picture, very old picture that was on paper, and of course digitized from my last year of medical school in 1989. And I don't know if anyone can recognize me here, but I will help you. That was me those days, very young and with a mustache, and those, again, some of these people, two people from there are still my very close friends, and I still talk to them, and again, some of my best friends are still from those years. So what I wanted to just I prepared this talk with this team, and we as pediatric oncologists, we make a lot of decisions in the face of uncertainty. And I think this quote it really summarizes what I want to bring up and make, hopefully, you think together with you just during the course of this hour, that we deal with life-threatening diseases, right? And we deal with parents, patients who are scared and who are, many of them know that they can die if the treatment doesn't work. And as Dr. Zülfikar also mentioned, there are a lot of implications what we do. It's not just a survival. What we do can have late consequences, and a lot of patients who survive their cancer, they die because of what the treatment has done to them. So we have a very difficult task. I want to cover this theme by trying to answer the following questions, which are the controversies. And I'll start with just quickly reviewing the risk-based standard of care for rhabdomyosarcoma in the United States. And there is a controversy for the standard of care for intermediate risk group. We're going to start with that. And then I will address, if the time permits, the three questions. Do rhabdomyosarcoma patients treated in the United States need maintenance therapy, which is now become a standard of care in Europe for some patients? Should we resect any residual mass present at the completion of therapy? This is a rare situation, but it happens. And then the question comes, the parents ask, the patients ask, hey, I have this mass here, you see in the imaging, or I can just feel it. Why don't you take it out? So I think we're going to cover that. And then lastly, I want to cover just the question, does surveillance imaging matter? Once the treatment is over, we get routine imaging just every 3 months, every 4 months, depending on where we are. And does that change anything? Does it save any lives or improve quality of life in these patients? So let's start with the risk-based standard of care. In the United States, there are 3 risk groups that the treatment is based on. And those risk groups classification is based on consecutive data collected through cooperative group rhabdomyosarcoma treatment protocols, and starting in 1972 with the IRS-1, and through the last IRS protocol 5 that was completed in 2005. So your current standard of care risk groups are based on the data analyzed on those protocols. At the end of those IRS protocols, in early 2002, Children's Oncology Group has been formed, and since then, the protocols have been named ARST, and with the numbers, of course, followed after that. And there have been minor modifications for these risk groups, so I'm going to cover for those, and then tell you also about what are the possible, what are the current changes that are coming to those risk group classification. The traditional risk group variables are created using actually 4 variables. The one is TNM stage, which uses the site of the tumor, the size of the tumor, and then whether there is involvement of locoregional lymph node. The classic TNM also includes invasiveness, but for rhabdomyosarcoma, that doesn't have any bearing. We don't include that information, although this is called TNM. Clinical group is based on the extent of surgery that is done upfront. So you get a complete resection with clear margins, that's group 1. If you did only a biopsy or a subtotal resection, there's still residual tumor, that's group 3. And both stage, TNM stage, and clinical group, if there's metastatic disease, then they're 4, stage 4 and group 4. FOXO1 fusion, which is seen in 80% of tumors that had alveolar histology, is now a very important variable. Previously, this variable was histology was used instead of fusion, but the last 2 protocols, protocol series in COG, instead of the histology, we're using the fusion. And then age only matters in just one particular group, patients with who have fusion negative tumors and that are with metastatic disease that age younger than 10 or 10 or older brings them into 2 different categories. So this is a busy slide. I put this shows actually that risk group assignment is actually the most powerful predictor and prognostic factor in patients with rhabdomyosarcoma. The curves are so very separate. And then the 3 groups, low, intermediate, high. I'm not going to go over of each item for those, but those are the patients that are in each group. The low risk group have 2 subsets that are color-coded in the slide, subset A and subset B, and they do have a slight difference in terms of their outcomes. So we're going to go one by one. What is standard of care? And we'll start with low risk. The current standard of care for low risk patients is based on 2 consecutive COG cooperative group protocols. D9602 was published in 2011, which used 2 different regimens for the 2 different subsets. So subset 1 received 47 weeks of just VA only, vincristine and actinomycin, no cyclophosphamide. And then the subset 2 patients were treated with same period, but with the addition of cyclophosphamide. So it's a high dose VAC protocol. When I say high dose, it's the 2.2 grams per meter square each cycle. And the results of the protocol was published, and it was excellent. It just both groups had more than 80% event-free survival, and the overall survival again for both groups were more than 90%. The following protocol aimed to decrease the duration of treatment and also the intensity, the total cumulative dose of cyclophosphamide for both groups. So subset A only received a total of 24 weeks of therapy and 4 cycles of low-dose VAC and 4 cycles of VA. And subset B, or 2, they were called subset A and B in the first protocol and subset 1 and 2 in this protocol, received again 4 cycles of VAC, and this was again low dose, and then a total of 47 weeks completed, the rest without cyclo, just VA only. So both groups got only total of 4.8 grams per meter square of cyclophosphamide, which was a revolution. I mean, I will talk about that, why that decision was made. So this was actually ended up with one win, one lose. So on the left side, for subset 1, it was a success. The results, the excellent survival, event-free and overall survival rates seen in 9602 with a much higher dose of cyclophosphamide was replicated. So again, EFS was higher than 80% and overall survival was 90+%. But for subset 2, the event-free survival rate, as you see here, was much lower than 9602. So this was chosen to be a wrong choice, and the patients should not be treated with 0331 subset 2 protocol. So for low risk, the standard of care for subset 1, seen in the top, it's either you can use a VA for close to a year using 9602 alone, or the short 24 weeks of low dose VAC and VA. So we offer both of these and let the parents pick. So just 4 cycles of cyclophosphamide, low dose, how much does that add to second malignancy risk? How much does that add to infertility risk? We don't know. We don't have the long-term effects, but it's not zero. So, and we let the parents pick. For subset 2, which is seen in the middle over there, those patients should not be treated with 0331, and current standard of care is really high-dose VAC, unfortunately, using 9602. They were included, they were eligible for the recently published 1431 intermediate risk protocol, and we don't have the results on how they did with that protocol, which used low-dose VAC-VI backbone. And then recently, in the current open ARST protocol 2032, a new very low-risk group has been created. That's stage 1, group 1, and that group is being treated with only VA, no cyclo, just for 24 weeks. This actually has been already done by the European group in Rhabdomyosarcoma 2005 protocol, and with excellent results. So this is done and under protocol, but that should be a standard of care for that group as well. So now on to high risk, before we go to the intermediate risk where there's more controversy. That's about 15% of all the patients. And that group, again, standard of traditional historic data-based 2 groups in this group are fusion positive or alveolar rhabdo in histology with metastatic disease, or fusion negative embryonal patients with metastatic disease who are 10 years or older. And historically, again, this group doesn't do well. 4-year event-free survival rates are between 20 to 30%. So, and multiple protocols have been published using different regimens, high-dose VAC on the left from IRS-4, show, again, a similar curve over there. And then D9802 used a similar protocol with the addition of initial phase 2 window with vincristine and irinotecan. Again, the results were the same. Then came ARSD 0431, which intensified therapy by adding blocks like we treat Ewing's sarcoma, a Q2 week, every 2 week, alternating Vadriac with ifosfamide etoposide, in addition to vincristine irinotecan and some VAC This treatment was about a year. The toxicity was quite high, and the results have been published in 2015. So what it showed here, actually, just the bottom line, it didn't show any improvement compared to high-dose VAC in patients when they are described as alveolar metastatic or fusion-positive metastatic. The results were very similar. And this protocol also includes patients with embryonal histology younger than 10 with metastatic disease, only 20 patients, as seen in that table 3. That group traditionally has 50 to 60% outcome using high-dose VAC and has always been part of intermediate risk group. Here, just for the protocol purpose, it was included in this protocol. And as you see in the table, it showed exactly the same result with high-dose VAC and with a lot more toxicity. What this paper also did used Oberlin criteria, which is those criteria are shown in the table on the right, based on analysis of close to 800 patients treated on US and European protocols published in 2009, and show that if you have more than 2 or more of these criteria, your outcomes are extremely poor. If you have 1 or 0, then your outcomes are can be good at 60 to 70%. So that when they analyzed the data based on Oberlin criteria, that was also shown. But again, this protocol did not show improvement over historic high-dose VAC. And what also has been shown is increase in overall over time the intensity and the dose of cyclophosphamide has not made any improvement in this population. So low-dose VAC is actually the standard of care, the backbone for all current protocols for this group. And of course, it makes sense because high-dose VAC is much more toxic, compared to low-dose VAC. And definitely there's a big difference between quality of life for patients with getting low-dose VAC versus high-dose VAC. Low-dose VAC is completely outpatient. High-dose VAC, they have to come in overnight, 1 day, but still it's an inpatient protocol with, again, a lot more toxicity. The current, actually, it's just got closed. Most recent COG protocol for high risk, 2031, used low-dose VAC backbone, randomized patients to plus or minus vinorelbine, replacing some of the vincristines. And they all got a maintenance therapy, 6 months of cyclovinorelbine, just like the European maintenance data. The results are pending. We don't know if that made a difference, but this protocol accrued very quickly. And it was the first actually randomized protocol done in patients with in high-risk group. So here comes the first controversy. Intermediate risk patients compromise half of the patients that are diagnosed in the world, and those are all localized fusion positive alveolar patients. Group 3 patients with fusion negative embryonal tumors, which means unresected. They had upfront only had a biopsy or subtotal resection, who also has stage 2 and 3, and that means all patients in unfavorable locations. And then the other historic group, in the patient group in the intermediate risk is younger than 10, fusion negative, embryonal with metastatic disease. So this group, we always had randomized clinical trials trying to improve upon high-dose VAC. So this was 9803, published in 2009, randomized between high-dose VAC versus VAC alternating with vincristine topocyclo. Topocyclo is an active combination that we use in our relapse patients frequently. And as you see here, no difference. Pretty decent outcomes, just around 70% event-free survival. And then before 9803, multiple other combinations have been used comparing with VAC, including drugs, cisplatin, doxorubicin, ifosfamide, etoposide, the carbazine. And again, that didn't make any difference as well. So cyclophosphamide, cumulative cyclophosphamide dose over the years have slowly been increased up to 30.8 grams per meter square in D9803. And when that was compared with the VAC VTC, which was 24.2, there was no difference. So with the next generation of protocols after the D series, for example, ARSD 0531, and also, as I mentioned earlier, with 0331 for the low risk, the decision was made by Children's Oncology Group's Rhabdomyosarcoma Committee to decrease the dose of cyclophosphamide. So that's what's done also for the intermediate risk group in the 0531 protocol, which randomized low dose VAC with VAC VI. So the cumulative dose in the VAC arm was 16.8 grams. So that was a big drop. You know, it was a big change, very brave change. And then with the well, let me just show you. And why did they do this? Again, just over the years, this increases in cyclo did not make any difference. And there was also an example from the European protocols. They used total of in the higher risk patients 9 doses of ifosfamide, 6 grams per meter square each. We're going to look at this in the maintenance question later, which, you know, total equivalence of that is around 16, 17 grams. So those were encouraging evidence that, you know, why don't we can do this. In 0531, there were 2 questions though. So one was lower dose of cyclo, and then we're going to randomize with VAC VI, which again alternates. So total 7 doses of low dose VAC, and then 7 cycles of VI. And then the second question was, can we, if we do radiation therapy early, at week 4, can we improve local control? So you can also question that, was that a good idea? Why did we ask 2 questions, you know, at the same time? And if the results are going to be different, how will we know which one didn't make the difference, or, you know, we had a failure? So unfortunately, we didn't get the results that we really wanted to see. So on the right, on the left, I'm repeating the curves from the 9803. The one finding from 0531 was there was no difference between low dose VAC and VAC VI, which was actually it's a very good finding. But what the event-free survival curves was actually about, in average, roughly 10% lower than D9803. So here's a table that's comparing actually with 3 groups within intermediate risk. So the largest group is the group 3, stage 2-3 embryonals, and 053, 65%, 4-year EFS, D9803, 73%. And there was 8% an absolute difference of EFS with a statistically significant p-value. And there was adjustments done for the variables that can be adjusted, and that didn't change that outcome. Overall survival rates were similar, 77% to 79%, and with a statistically not significant, you know, p-value. And then when you look at the alveolar groups, which are, you have to be careful, smaller subgroups, there was 7% absolute difference in the stage 1 group, you know, patients, 69 to 76% with a statistically non-significant p-value, and no difference in overall survival. And then for the group 2-3, stage 2-3 alveolars, 51 to 58%. So again, about 7% absolute difference, but p-value is 0.14. We're going to come back to this table later because I think this is so interesting for us. Like when you see these numbers, how do you make a decision? If that p-value, you know, for the embryonals wasn't significant, or was it was 0.06 or 0.09, how would you interpret this data? How would you make this decision? So this created chaos. This really rocked the community, And if we were all divided, how we interpret these findings, then there was a follow-up publication, looked at what happened to local control in 0531. And on the left, actually, you can see some differences between the two protocols. So there were more patients with perameningeal location in 0531, and 45% versus 39%. And then because the times were changing, there were more patients treated with protons in 0531 as well. Slightly up, there were more patients that didn't get radiation compared to 0531 in D9803. So you can think about how those may affect the results, but these were all adjusted in the analyses. So one finding from the protocol was also that patients who had tumors that are larger than 5 centimeters had more often, up to 30% local failure in 0531. And then when the two protocols were compared, there was more local failure in 0531. So that was probably the main difference between why did we see that EFS difference. Even after adjustment for the variables seen in that table 2, local control was inferior in 0531. And of course, the question was, did this happen because of lower cumulative cyclophosphamide dose? And a lot of people, most people believe that is the case. But there were a lot of other differences between the two protocols. Are we comparing apples and oranges? We don't have a randomized controls trial. So how do we how do we take these results seriously and treat everybody with high dose vax? So those were the questions that were asked. What were the differences between the protocols? There were differences in eligibility and classification criteria. There were undifferentiated sarcoma group they were not in 0531. That probably didn't change the results that much because average survival for those are about 60%. The embryonal group that is younger than 10 with metastatic disease also were excluded from 0531, which should actually again not change the results. There were different definitions for alveolar rhabdo, so that's important. And how would that make a difference? We don't know. So in D9803, any alveolar feature would have been called alveolar for AST 0531. It had to be 50% or more. There were differences in population between the two, as I mentioned, especially for location. There were more perameningeals of 0531. And another big difference was how we did local control. In D9803, local control was at week 13, and 54% of the patients had delayed primary excision. They didn't get radiation up front. So when 043, actually that's 0531, mistake. When the radiation was given at week 4, everybody got higher dose. Everybody got 50.4, and that only 16% had a delayed primary excision. Most of them at right before week 4, if there was a response. And then there was also difference in time periods, 1998 and then later 2000s. So those were questions asked. How do we interpret this data? Then there was the 1431. That's the most recent protocol that was completed while 0531 results were being analyzed. Used a VAC-VI backbone, randomized VAC-VI alone versus VAC-VI plus temsirolimus, and those results are just again recently published, and they were very similar, to VAC-VI. So confirming that, this is around 60-65% EFS, using this backbone, and the other finding, temsirolimus, did not make any difference. So what is the questions being asked? What is the ideal cumulative cyclophosphamide dose? Did we drop it too much? With low dose VAC 16.8. Is it somewhere between 16.8 and 24.2? That was the total with the VAC VTC in the 98.3 arm. The Rhabdo 2005 European protocol, again, as I said, uses for the higher risk groups, uses total 9 doses, 54 gram per meter square ifosfamide, which approximately it is equal to only about 13.5 grams per meter square of cyclophosphamide. So, and those results are actually close, maybe a little bit 5-6% lower in average if you compare groups side by side. So again, this is a question that is being asked. So I'll bring it back to this table. So how do you interpret this data? And maybe we can have discussion at the end on this. Do you just take that p-value and 8% difference and say, I'm going to treat all embryonal patients in the risk group with the higher dose? Yeah, we don't have a randomized clinical trial, but that's a difference, and that's what we're going to use. Or you can say, hey, there's no difference in overall survival, and why am I going to subject these patients to a more toxic regimen and change their quality of life and potentially have long-term consequences? What do we do for the alveolar groups? That there's a difference, but the p-value is not significant. Do we have enough power to make that difference statistically significant? So all those things are actually, in the end, we can discuss. It depends on your personal bias, how you interpret the data. And so currently there is no standard for intermediate risk. And some use high dose VAC, some use low dose VAC, some use low dose VAC VI. What's being discussed, what will be the next randomized controlled trial in COG, is actually most likely it's going to be high dose VAC randomized with low dose VAC VI plus maintenance. So we're going to compare, most likely, again, this is still being discussed, not for certain yet, but that would actually be a very good question, right? Just to answer the dilemma that we're facing here, and in about probably 6-7 years, we would know, what is best. But until then, we're all faced with this question, and then we would just make our own decision. What is the best treatment for this group? So I'll keep going on. We only have 15 minutes till the end. I don't think we're going to be able to finish all this. Maybe we'll do another talk later on. So the other question I brought up is, do rhabdomyosarcoma patients treated in the United States need maintenance therapy? This is the 2005 protocol from that's published in Lancet Oncology in 2019 from the European Cooperative Group. So the high risk that they randomized group that they randomized maintenance is not exactly intermediate risk that we have. It includes patients from low risk, subset 2, and excludes some of the intermediate risk patients that we have. So very high risk group is alveolar with lymph node positivity in this group. So they randomized this group to, there were 2 randomizations. One, their standard IVA versus IVDO, the addition of doxorubicin initially, and after 9 cycles, if they were in CR. Only the patients who were in CR, they were randomized to getting maintenance therapy with vinorelbine and cyclophosphamide. And those results have been published. Very nice separation between the two. About 32% decrease in events for patients who had the maintenance, and there was also an overall survival advantage as well. So this was excellent, and Europeans now changed their standard, and that's what they do in that group. So that brought up the question: okay, should we use this in the United States in our patients? And with that data, 0531, 1431 was actually amended, and those patients did receive maintenance therapy after a certain time point based on this data, and also based on the 0531 data that I showed you with the inferior results compared to high dose VAC. So when you look at the cumulative cyclo doses, as I showed you earlier, at the top, rhabdo 2005 European protocol, only 13.5. With the maintenance, it goes to 17.7. And then the 9802, whopping 30.8, grams per meter square. And if you add the maintenance, you're going to 35. 0531, low dose vac arm, 16.8. So if you add the 4.2, you're going to 21. And that 16.8 is very similar to 17.7, that the European protocol. And then for 0531 and 1431, the low dose vac VI arm, and that's a very low cumulative dose, 8.4. And then if you add the 4.2, you go to 12.5. So then I think, how I interpreted this is just if you're using high dose vac, definitely you don't need the maintenance. I mean, you're already giving a lot of, that's very simple, right? I mean, you can answer that question. But believe me, there are some people in the United States give maintenance therapy in patients even who get high dose vac. And for low dose vac arm, I think it's questionable. I wouldn't do it because, again, just 16.8. I don't think there will be a difference between 16.8 and 17.7. I think it only makes sense if you're using the low dose vac VI arm, 8.4 plus 12.6. But I think one can argue that's even less, and should you even use low dose vac VI? But that might be the only time to use the maintenance regimen in the United States. Another quick topic to cover will be what should we do with the residual masses that are present at the completion of therapy? So that is a very difficult question, and as there's not great data to answer that question. But there are two papers that I'm going to show here that trying to we can gather some information. So this is from IRS4 data, which, the publication actually the goal was, is there a difference between responders and no responders? So patients who went into CR and didn't, who had a partial response or no response, and using IRS4 protocol, there was no difference. And there were at the same time some data from Europe that showing there may be a difference based on the response. But 17 patients who had partial response or no response, who had residual tumor at the end of therapy, underwent a procedure, again, at the end of therapy. Some had resection, some had only biopsy. And there was no difference in terms of nominal difference, 71%, 80% for the resection. Out of 16 patients that path was available, half of them had a viable tumor. So that was interesting. And 3 were completely resected. Of course, the ability to resect strongly correlates with the location. If you resect it, usually, if you can, if it's in a perimeningeal or in a difficult to resect place, so there's a bias there in terms of where you do. And then there was a follow-up paper based on the data for the next 2 intermediate risk protocols, D9803 and ARST0531. So many numbers there I'm throwing at you, so I apologize for that. So that actually showed that there was a difference based on the response, and that was present in the perimeningeal tumors. And when you excluded patients without the perimeningeal site, there didn't seem to be any difference for response being associated with outcome. But in that data set, there were 26 patients who underwent an end of therapy procedure. And the ones who had the procedure, outcome was 88.5%. The ones who didn't, 71%. So there was a little trend there, right? We just I think you cannot say there's no difference there. That's about 17% difference in outcome, not a statistically significant p-value, but we're talking about only 26 patients. And interestingly, majority of these were just biopsies, and location again was correlating with what you can do. Only 5 out of 23 that we had available path results had viable tumor cells, so it wasn't as high as 50% with the previous data. And there was morbidity associated with the resections. That in one patient deferens was resected, and then one patient actually had an orbital exenteration. So, and that's the best data that we have to answer this question. So then what should we do, right? And how do we discuss this with our patients? Because the patients will ask for this, right? I mean, they will themselves bring it up. And so I think the simple answer is, should be no. Having viable tumor is rare at the end of therapy, residuals, and there's really scarce data to answer the question. But you can also think lack of data does not mean absence of a relationship between resection and survival. I only do this if the procedure is not going to lead to a significant clinical or cosmetic morbidity. I think then this can be considered for an extremity tumor. Like, it's not going to cause, again, a significant injury or morbidity. So I think, and that's what usually the practice is. And then there was a recent recommendation from a group of surgeons from Europe and US. And the panel here did not recommend late resection after completion therapy if there was a residual tumor, but they also qualified that this is a really weak recommendation. The evidence, as I mentioned, is actually very low. So I think we should stop here. I do have one more topic to cover, but this may take 8-9 minutes. What do you think, Dr. Kebudi? Should we stop?
Well, I think we have. I think people are interested, and we have almost 200 participants. So maybe you can briefly go over the surveillance images as well.
Okay, I just want to make sure we have enough time for.
We have 20 countries, almost 200 participants at the moment. Yeah.
Okay. That's wonderful. Okay, I'm glad you didn't tell me that in the beginning. So the question is, does surveillance imaging save lives in Rhabdo patients after completion? Does it matter what we do, right? I mean, everything, I think, just another message here. We should always question ourselves, being a healthy skeptic. Does it really matter what we do to treatment or surveillance imaging with patients? So quickly going through, the audience probably knows this already. Relapse rhabdomyosarcoma patients have a very poor prognosis. Average survival is around 20-30%. So for majority of the patients, even if you pick up a relapse by scan or a symptom, it really won't matter because you don't have any curative therapy, and that has been repeated with multiple relapse rhabdo protocols. There are some prognostic factors that are associated with better survival. So this is based on our data from 5 different institutions. And so what matters for these patients is time to relapse, if they relapse, and those are all summarized in the table on the right. If you relapse quickly of therapy, your outcomes are poor. Your risk group at diagnosis actually is a very strong predictor. The low-risk patients have probably the best chance to survive. High-risk patients have very little chance to survive. Again, this is at diagnosis. And intermediate risk is sort of intermediate. Location was also correlated, with outcome. If you don't get any radiation at all, or if you have radiation after relapse, or twice before and after relapse, your outcomes were better. So this was interesting. So many times after relapse, we question, should we irradiate again? Just because this patient already had radiation. And that actually is associated with improved survival. And another important variable, surgery. So should we be aggressive and resect the recurrent tumors? And this data set in a reasonably large sample size, 127 patients, did show that in a multivariable analysis, that repeat surgery is also associated with improved survival. So the ideal screening study it detects a disease early in an asymptomatic person, should decrease morbidity, and should decrease mortality, more importantly. So it has to be sensitive and specific and based on a gold standard test. We don't have a gold standard test for rhabdomyosarcoma. And false positives, as you all probably know, lead to further workup. You get more imaging and you get unnecessary biopsies. So you can really cause harm with false positive results. There are two biases, well-known biases, associated with screening studies. One is a lead time bias. So assuming that all patients will die at the same time, when they start getting a sign or symptom, if you didn't screen them. So when you screen them, you will pick patients up before they have a sign or symptom. And that's the time from picking the patient up with the screen and to the time that they will develop signs and symptoms, that's the lead time. So when you do the analyses, you will have longer survival within the patients that you picked it up with the screening. And another bias, important bias, that again will be in favor of the screening in terms of prolonging survival, is the length bias. The test will pick up slowly progressing. There could be biological difference between two groups. There's some will progress really fast because they're biologically aggressive, and then others will slowly progress. And so the ones that are rapidly progressive, they'll most likely be picked up in between scans. And then the ones that are slowly progressive, they will be picked up with the scan, again, biasing the outcome for a longer survival for the screening. So there are no evidence-based guidelines for imaging frequency. There's actually, just I will share the data just that has all come recently for or against doing surveillance. But for years, we never had any data. So this is sort of the, again, there's no official recommendation, but this schedule is from the most recent COG protocols that first year you do every 3 months. So imaging of the primary tumor, which could be MRI or could be CT. And then for lung surveillance, you do chest X-ray. So first year every 3 months, second and third year every 4 months, fourth year every 6 months, and then one more scan for the 5th year. So that's total of 13 time points. And imagining that, around 400 patients newly diagnosed in the United States, that ends up being 4,000 or 5,000 scans every year happening. That's a lot of scans. And possible long-term effects are now being described from MRI contrast. And then well-known side effects of sedation. Many of these patients are young, so they need sedation for the MRIs. Once the treatment is completed in the US, people pay out of pocket. There's out-of-pocket max for their insurance. And I recently had a scan and I had to pay $2,000 for a PET CT. And these MRIs are actually more expensive. And there's well-known anxiety associated due to imaging. And then with the CTs, CAT scans, and some people even do PET scans in surveillance, there's exposure to additional radiation. So actually, we first published this small paper in 2015 in PBC in just 42 patients. This is the quickest paper I've ever published, and just showed that if you pick up relapses by imaging versus just symptoms, there is no difference in the curves. It's just when you look at them, and there was no statistically significant difference. Overall survival was 20% versus 11%. Then while we're working on a larger sample, our European colleagues published this wonderful paper in 199 patients in 2019. They showed very nicely on the left curve the lead time bias that patients with the blue line who had the routine imaging, they were diagnosed in average, picked up early compared to patients who had symptoms. But on the right side, they also showed there is no difference in terms of survival once the relapse is picked up. And then we published our larger data set, from 5 large institutions in North America. And again, we showed no difference. And as of note here, I didn't mention, it's 50-50 that patients are diagnosed with relapse with signs and symptoms versus imaging. So based on these data, what do we do, right? There's no randomized clinical trial to answer the question in a healthy way. You have to do that. But That would be a very difficult question and probably unethical, and you would not be able to do that study in a prospective randomized clinical trial fashion. There's ample observational evidence, as I showed you, that there is no association with prolonged survival with the screening. High-risk patients at diagnosis have no curative options available after relapse. Maybe patients who can survive after relapse may benefit from surveillance imaging. We don't know, but that's a group that we probably should do these imaging studies. Of course, the question is, like, let's think about the other side. Even if patients who are not going to survive, would they have a better quality of life? Would they have less symptoms if we pick the relapse early on? So that can be a nice study question that we're interested in. And the other part that we are also currently developing a project is, what is the patient perspective, patient parent side? What do they think about imaging? Maybe they feel anxious, but when they have the studies, they feel better. If they never have any imaging, they will always be fearful. And I'm sure there will be a subgroup of patients, parents will be in that category, and that the scans may be beneficial, for them. But those are other questions that I think should be addressed. But what has been done, which was great, initially European group published their own and changed their strategy. And then this paper came in 2023 with authors from both sides of the ocean. And so for patients with localized disease, they recommended for 2 years, Q4 months, every 4 months, imaging with the primary, site imaging, MRI or CT, and then just chest X-rays only for 2 years. After 2 years, which again, most of the relapses happen within the first 2 years, they only recommend it just for just whenever there's a clinical symptom. And for patients with metastatic disease, if they had 1 or less Oberlin risk score, which has a chance, to survive with appropriate treatment, they recommended the same thing, 2 years. And then for everybody else, patients who had metastatic disease and high Oberlin risk scores, they actually bold and bravely said that a more individualized surveillance approach based on shared decision-making between patient, caregiver, and physician. So they did not recommend, set every 3-4 months imaging. So that was actually great. Just using this data, coming up with change in standard of care was just a great outcome for these papers. So just ending now, I think as to conclude based on what I've covered, as pediatric oncologists, most often we make decisions for our patients with little or no reliable valid evidence, right? High-dose VAC versus low-dose VAC VI. Why is that important? How do we make that decision? More toxicity versus less toxicity, maybe better survival, 10% less survival, long-term effects. Do we resecting end of therapy residual masses? These decisions matter. These are really, we should not make these decisions in a light way, and think thoroughly. What do we use? We use your critical appraisal skills of the literature, and personal experience also does matter. So if you're a young practitioner, talk to your experienced people like Dr. Kebudi and other people in your team. I think that's very important. And then including parents. I mean, we are having difficulty making. We should have difficulty making these decisions. And it's going to matter for a person that's in front of us. So if the patient is older, teenager, get them involved, get their opinion. What are their biases? What are things that are important for them? If not, get the parents involved and make a shared decision together. And I think that's, the most important thing is, main goal has always been taught to us in the medical school is to do no harm. And I think, there are some other, I'm just preparing for another talk for the future. There are some other unanswered questions, and controversies. Why are there differences between US and Europe? Why, and does it make a difference? Ifosfamide versus cyclophosphamide. I mentioned some of the differences. And another big one, I really wanted to get into that, but this is a big topic. What is standard of care for relapsed rhabdomyosarcoma? That again is controversial. So I stop here, and again, sorry for the late start and then just going over 10 minutes. But thank you again for the invitation, and I hope this was helpful to most of you.
Dear Professor Fatih Okçu, thank you so much for this very comprehensive lecture and covering so many controversial questions. And as we have to take the promise for a second seminar for the questions that you have shown in the last slide. We need to discuss those as well. Now, I think, sorry for this was a new platform. Thank you, Professor Nergis Dağoğlu, for having the platform. There were some technical difficulties. Thank you for starting a bit late. And for the ones that missed a part of it, this has been recorded. And if our guest speaker consents, it will be put, and he says, yes, we'll get that in writing as well. And it will be, the link for the recording will be sent to you by email because you have your emails in the platform anyway. So, dear Fatih Okçu, thank you so much. So we have listened to you, many controversial questions, especially for intermediate risk. Shall we use maintenance? So the answer, we are using the high dose VAC with 2.2 grams, it seems that we do not need a maintenance. For the ones that are using the low dose VAC, now there will be a randomized question, as you have said. But then that is also controversial. It has to be answered. Especially you have put forth that the local control is very important in that group of intermediate patients that had the low event-free survival. The survival was okay, but the event-free survival was a bit low. In the two regimens, the D with the RST, we saw that the time of the radiotherapy and the dose of radiotherapy because of the time was different. So we always have to think multidisciplinary, both the chemotherapy and the local therapy is so important. For the residual mass, this is a very important question that we always discuss in tumor boards. So if it can be resected with no morbidity, we may, but otherwise, if there will be morbidity, as Professor Okçu has said, please do not resect and don't lead to morbidities, especially in old days, Dr. Rainey would say, like in the parameningeals, if they are stable for more than 6 months, you can leave it. Do you suggest the same? Probably, Professor Okçu.
Definitely. And,
yeah.
And then lady was one of my mentors, actually.
Yeah, I know. I mean, now at least we are commemorating one of the big names in rhabdomyosarcoma in this good lecture. Yes. And the surveillance, I'm happy that we had those few more minutes so that you could go over the surveillance in imaging. Do we need it or not? That was really a controversial question that at the moment still it is, no one says do not do it, but still the data there is, it is not randomized, but there is data that it can be at least reduced, as you have suggested, the instruct that you have done with North America, Western Europe together. The 3 suggestions that you had is really very important, both for health economics, for reducing the anxiety of parents. And you have also mentioned something very important, shared decision-making with the parents and the caregivers is very important when we're following the patients. So this was really a very comprehensive, very important lecture. And we are getting your word for the second lecture to have the other controversial questions, to discuss them. And we thank all our participants. We had almost 200 participants from 20 different countries, all continents that were represented in this lecture. Thank you so much for being with us. Thanks, Professor Zülfikar, our co-moderator, our rector, for being with us. And all our participants. We thank the Istanbul University, the AVUZEF that does this platform, Dr. Nergis Dağoğlu, also SIOP for endorsing this very important lecture series, and all SIOP members and non-members who have been with us here from all over the world. And we hope to see you in the next seminar. Thank you, Fatih Okçu, once more.
Thank you. Thank you again for the invitation. It's an honor again just to be here, and my pleasure. If there are any questions, that please send them to me. And
we did not receive any questions. I think they were so many. They had to listen to you so there were so many nice things, all the questions marks that you have put forth. That's, I think, why we didn't have the questions. So everyone wanted to listen rather than writing the questions. And if they have questions, they can write to us, and we can, in fact, afterwards refer them to you and get back to them. And in the next seminar, we can, in fact, answer those questions that were unanswered. Thank you so much again.
Okay. Thank you again. Thank you for the invitation. Well,
Thank you.
bye-bye.